Good morning, Madhur. Good morning, Madhur. Utsav, good morning.
Morning, sir.
Yeah, so you will present one case,
Yes, sir.
the renal mass.
Okay, sir.
Okay. And Madhur will present PUJ, right?
Yes, sir.
Madhur is there or he is sleeping?
Sir, I'm here, sir.
Okay. Good morning.
Good morning, sir.
पहले कौन सा करना है?
पहले मार्च
Good morning, everyone.
Good morning, sir. Good morning.
Good morning. Can you record this program?
Yes, sir. We can record, sir.
Okay. Record it and send it to me. Okay.
Okay, sir.
Okay.
Uh, who is the candidate? Who is the examining?
From KGMC, who is taking the case?
Sir, Dr. Sahil.
Okay. Shahil, you are taking one case or you are taking both?
Sir, one PUJ.
And second case?
Hello, good morning, sir. I'm Dr. Shashiraj, sir. I will be examining a case of renal mass, sir.
Okay, fine. So I think we'll wait for 2-3 minutes, then we'll start. So good morning, all.
Good morning, Sanjay.
Good morning, sir. So I welcome you all for this session, and this is a little different model. Normally, we used to present from one institute, but I have combined both institutes so that the learning would be little better, and second is the attendance would be little better. That is, I think, my main purpose. So we have two cases. One is Trivedi sir is there. Samir sir is there, sir.
Yes, Sanjay, good morning.
Good morning, sir. Good morning. I
Excellent
think
idea.
yeah, I think Ansari sir will join within a minute or so. So I'll take the second case first, like renal mass, because once Ansari sir will join, then we can take the PUJO. It's a pediatric case, so he will give
Yeah.
more input. Ansari sir is already joined, sir. So I think we can take the first case, the PUJO first, right?
Okay.
Okay, sir. So from our side, Dr. Utshav, who is a postdoctoral fellow, and Dr. Madhur, who is third year, they will present the case. And from KGMC, I think Dr. Shahil and Dr. Shashiraj will take the cases, right?
Yes, sir.
Okay, so Dr. Shahil, I think you will take the PUJO, right?
Yes, sir.
Yes, sir. Ansari sir, good morning, sir. Hello, good morning, sir. Ansari sir, are you there? I think he's there, but so we can't hear you. I think there is some problem in network or so.
Sir has not connected his audio, I think, sir.
No, no, audio is connected. Open. Anyway, go ahead with the case.
Hello.
Good morning, sir. Sir, so we're going with the case, sir. Hello. We can't hear you, sir. Yeah, Mother, go with the case. Unnecessary.
Sir, going to the first case. The patient is a 7-year-old male child who has presented with pain and fullness in left flank for 6 months. How would you like to proceed?
There is some noise from some. Yes, okay, go ahead.
Hello.
Go
Is
ahead,
this-
Mother. Yeah.
Sir, the patient is a 7-year-old male child who has presented with pain and fullness in left flank for 6 months. So the next, how would you like to elaborate the history, sir? So that's the first thing, sir.
Sahil, I think you need to answer.
Yes. Yes, sir.
So the first question would be,
How was the character of the pain? Was it associated with hematuria or anything else?
Okay. Apart from that, what else would you like to know about pain?
Any fever?
Okay.
so Sahil, whenever a patient like this or
Any
a boy
micturition?
like
How
this,
was it? Yes, sir.
when a
Any
boy
pain
like this will come to you, so first going before a subsequent history, certain things will come in your mind. So flank pain for a 7 years old child. So once those certain things will come in your mind, then you will proceed accordingly for further history, right? So what are the things that is coming in your mind? Hello, Shahil, are you
Hello.
are you audible?
Sahil, you need to answer. The question is, what comes to your mind when you listen to this history? A 7-year-old boy who comes to you with flank pain and fullness. Sahil,
Hello. Network.
Sahil, you are not audible. I'm not sure whether you are speaking or not.
But he should also be visible. He is also not visible also.
Sahil,
Any other agent to take the case?
Sahil,
I
you
think
are muted.
Hello.
poor connection of this.
Hello.
Sahil, you are.
Hello. Sir, network.
Sanjay, I think otherwise it will delay the things. Let Madhur also, start something or may answer himself, something like that.
Okay,
What would-
Madhur, go ahead. So, with this history, at a 7 years old boy presented with pain and fullness for 6 months, what are the differential diagnosis that is coming in your mind?
Yes, sir. Sir, the possible differentials in a 7-year-old child presenting with the pain and fullness is left flank may be it may be due to urolithiasis involving the left-sided system, sir. And apart from that, sir, pelviureteric junction obstruction. It may just be recurrent pyelonephritis because of maybe vesico-ureteric reflux, but that is relatively less likely. So these are.
Madhur,
Yes, sir.
you need to answer in a fashion. You tell the first probability first. Okay. So
Yes, sir.
urolithiasis, to my mind, in a 7-year-old boy, with flank fullness and pain would not be the first differential.
No, sir. First will be pelviureteric junction obstruction, sir.
Yes. So
And-
why did you say stone disease? See,
Sir.
it's not just enumeration of the differential diagnosis. You need to tell the most probable diagnosis first, Okay,
Sir.
please carry on. Madhur?
Sir, after this, I would like to know the site of the pain character on-site duration.
Naim, Madhur,
Yes, sir.
Madhur, why did you say pyelonephritis?
Yes.
Sir, it is less likely, I said.
It is extreme. It is extremely. See, I know that you know the diagnosis. If you know the diagnosis, there may be some certain conditions which are straightforward. Then you need not to act and hide truth. We ourselves teach most of the time. Even if you know the diagnosis, please do not disclose it. But it does not mean that it becomes so obvious.
Yeah, you are saying urolithiasis, pyelonephritis.
Yeah.
These are very uncommon. Like in a 7 years, you should think of congenital causes first.
Yes, sir.
Like hydronephrosis because
Yes.
of pelvic junction obstruction.
Stone and a stone in pyelonephritis. A stone in pyelonephritis will present like this in a 7-year-old boy. Hydronephrosis, UDT, upper tract dilatation.
Yes.
Cause may be any. There are many multiple causes for this. Not only PUJ, there may be UVJ, there may be megaurator. Even reflux kid may sometimes present with flank pain.
Yes,
So,
sir.
what may be other benign conditions in 7-year-old which may present with this?
Sir, apart from this,
Sir, Wills tumor. It can be Wills tumor, sir.
Yeah, Shail is there now, right?
Yes, sir. Yes, sir. Network problem. Sorry, sir. Can be Wills
So yes, sometimes even the tumors may present. है ना? So So Sahil, now you take the lead and tell. Dr. Sanjay, please go ahead.
Yeah, Shahil, so what are the other relevant history you would like to ask apart from the character of pain?
Sir, whether it is associated with hematuria or not.
Madhur, you answer now.
How does it going to help you? What
Okay.
is the differential diagnosis that will exclude from the history of hematuria?
Sir, hematuria tumors may present with hematuria or upper urinary tract calculi. They can present as hematuria in a children.
Okay. So, Madhur, you
Yes,
go
sir.
with the associated histories.
Yes, sir. So regarding the history of pain, the site is left flank and the insidious intermittent onset and dull aching character without any reference or radiation of the pain, and there was no associated. There was mild low grade fever and vomiting on and off, and it has been there since 6 months and relieved by analgesics and sometimes antibiotics, and it is moderate in severity. And there is no hematuria as such, sir.
Any
There's no,
associated history, negative history?
there's no history of any hematuria, turbiduria, lithuria, acute retention, PUC insertion, or any urological intervention as such, sir.
Okay. So, Shahil,
Sahil, can
Yes,
you
sir.
tell why he has mentioned about acute urinary retention, PUC insertion with flank pain? You know, what could be the reason why this history has been presented?
PUC, sir, it can be it is a male child. It can be case of, sir, PUJ obstruction. PUV, posterior urethral valve.
So, why did you think in terms of PUV? What is the typical presentation of PUV?
Pain and decreased flow, fever.
Sanjay, you ask. It's your
no, sir. You please carry on.
no. You ask.
Okay, so what? Anything else you want to know in history, or this is all? Shahil, are you?
Yes, sir.
Yeah. Anything else you want to know in history? In a,
Any-
especially in a pediatric cases.
any-
Pediatric cases. Other
Abdominal distension, jaundice.
Okay, jaundice and all. There was no jaundice, nothing. So in pediatric cases, basically you should also inquire about the birth history, other congenital anomalies and all. Those are important, right? In pediatric.
Antenatal scans, में, sir.
Yes, those are important part of history, right? Pediatric. Yeah, I think there are lots of disturbances. Please unmute. Please mute other. Okay, so give the antenatal or other birth histories,
Milestones.
milestones, and all. Those are important history that you should ask.
Sir,
And constipation also is an important history in pediatric case group because many patients you see some voiding dysfunction related to bilateral hydronephrosis. So those are also important history like bowel habits, constipation, right?
Sir, in the perinatal, developmental, and immunization history, on antenatal scan, nothing of this sort was documented as per the informant, that is mother. And the patient was delivered with a full-term normal vaginal delivery, has attained normal milestones, and has been immunized up to date, sir. There is no history of any similar complaints or any congenital anomalies
Okay,
in.
Shahil, how will you proceed further?
I will go for sir ultrasound.
Without any examination, you'll go for ultrasound or you will examine the baby?
Sir, I will examine the patient first.
Okay. So examination findings?
Yes, sir. Coming
Sahil, you need to be specific. What especially you want to see in the examination? Don't ask for the entire examination. What special things, keeping the differential diagnosis in mind, you want to see in the examination?
So whether the swelling is palatable or not, it is rising from kidney. How is the swelling, cystic or solid?
Okay, so you are interested in the lump.
Yes,
Anything
sir.
in the general examination you want to see?
General.
Always look for the growth of the children. Whenever you are seeing any neurological problem, congenital issues,
Yes, sir.
so whether there is a evidence of CKD or growth retardation, all those are very important, right?
Yes, sir.
So this is a very important general examination that you, because if you look into a child who is PUV and with a raised creatinine, you will can appreciate seeing the baby. There is something abnormal with his growth and all, right?
Yes, sir.
Those are also very important.
Yes.
Sahil, what is your differential at this point in time? Are you keeping PUV in your mind?
Yes, sir. PUV.
PUV. What is against PUV after all this history?
No urinary complaints are present.
Okay. Age?
I think, Sahil,
Yes, sir.
more importantly, what is in favor of PUV?
So flank pain and renal mass, flank mass.
I mean, that is not very strongly suggestive of PUV.
And age of the patient. Male baby age of the patient.
Yeah, but without any LUTs, having a palpable renal mass, I mean, it's highly unlikely.
7-year age is, you think is suitable?
No, sir.
So what is the usual age of PUV?
1 to 2 years.
1 to 2 years. Think again. Madhu, what is the usual age of PUV?
Sir, it tends to present early on, sir, like less than 1
Yeah,
year.
it is an antenatal diagnosis these days.
Yes, sir.
Yes.
Nowadays,
So
yes, sir.
it is a neonatal diagnosis.
Yes, sir.
At 7 years, if we tell and is having slightly interest in the pediatric, then it will not be good. If the examiner is having some inclination. So 7-year PUV can only be unless there are frank LUTs.
Yes, sir.
Okay. So come to the examination, otherwise we'll not be able to finish 2 cases.
Sir.
Sahil,
Yes, sir.
chalo batao, Madhur, you tell the examination.
Sir, the examination findings of general examination are fairly normal. The patient is conscious, alert, cooperative, well-oriented.
So specific. Don't describe it. Normal is there is nothing. Then
Yes,
okay, fine.
it is normal, sir.
Right. Then what are the other abdominal examination?
So on abdominal examination, on inspection, there is no fullness as such, but on palpation, there is mild vague fullness in the left lumbar region. There is no definite lump or swelling palpable in the left lumbar region, sir. And otherwise, it is also normal, sir.
So Shahil, now what are your top 3 differential diagnoses? 1, 2, 3. You know the examination, the history.
Yes, sir. First is the PUJ.
Sorry.
Sir, first is PUJ.
First is PUJ. Second.
That can be cystic disease of the kidney.
Like
Multicystic dysplastic kidney.
multicystic dysplastic kidney. Okay. Third,
It can be VUR because of pure hydronephrosis.
viewer. So basically, it's a differential diagnosis of hydronephrosis, right? UPJO, it may be megaurator, it may be viewer, whatever. So apart from that, you said second diagnosis is multicystic dysplastic kidney.
Yes.
What is third?
Hydronephrosis due to VUR.
That you said no. Hydronephrosis is due to UPJO, obstructed megaurator, or viewer, whatever.
Yes, sir.
Second, you said multicystic dysplastic kidney. Anything else? No.
It can be renal mass, sir.
Yeah. Okay. So how will you proceed further?
Ultrasound.
Okay.
Blood
Anything-
investigations and ultrasound.
Any specific blood investigation you are interested in?
RFTs.
There is echo from somewhere. I don't know. I think
Dr.
someone is with
Dr.
two
Sahil, are you
devices.
logged in via 2 devices?
No, sir.
Okay. So any specific blood investigations you are interested in?
CBC RFTs. Routine investigations.
You are also interested in, by any chance, in urine routine or any urine examination? No.
Yes, sir. Urine routine.
So what you want to look into urine routine exam?
RBCs are present or not in pus cells.
So how it will give you a clue in your first differential, second differential diagnosis. First is say for PUGO, second is your MCDK. So how the pus cell and RBC will give you some clue. Any insight?
It is obstructed system. It may get infected, sir.
So Madhur, you go with the basic.
So these are the lab investigations. Serum creatinine is 0.7. Urine routine is essentially normal. There is no RBCs, WBCs. Culture is sterile. And ultrasound shows this kind of picture on the left side.
So what you can see in the ultrasound? Sahil, are you there?
Yes, sir. So this is a dilated system with dilated calyces. And renal parenchyma is, I can see it is very thin. Ureter is not visualized.
Yeah, I am saying this is a cyst. So how will you differentiate between cyst and hydronephrosis on ultrasound?
In hydronephrosis or in PUGO, all the cysts, they communicate with the medially located pelvis, whereas cyst is a thin wall structure that doesn't communicate with anything.
Okay. So what is the findings? Madhur, you tell the findings of the ultrasound? Yes.
Sir, on ultrasound, the left kidney is grossly hydronephrotic, 15.3 centimeter with parenchymal thinning, and ureter is not dilated. The anteroposterior diameter of the renal pelvis is 7.2 centimeter, and cortical thickness is around 4 to 5 mm at all the poles. The right kidney is normal, bladder is normal.
So Sahil, what is the why he has specifically mentioned about anteroposterior diameter? Does it make any sense to you?
Hydronephrosis grading is
Okay. So how how the anteroposterior diameter gets the hydronephrosis?
class 1, class 2, class 3 grade. Is it? So,
Can you enumerate those grading?
yes, sir.
Yeah. Apart from grading, what else it will tell you? Anything else you can think with this APD?
Yes, this moderate hydronephrosis is there, sir.
Okay, Madhur, tell the gradings. Do you have that?
Yes, sir.
Show the grading.
So these are the antenatal hydronephrosis gradings, sir. In
You're
the
talking about antenatal, right?
yes, sir. Sir, so then there is radiological grading of the hydronephrosis. That is also available, sir.
That is Madhu, you tell him SFU grading, है ना? That is the terminology, proper terminology. SFU 1, 2, 3, है ना? Not the antenatal.
Okay, sir.
It is applied in antenatally, but that is also used in postnatal also, because this anatomical findings are the similar.
Yes, sir.
है ना?
Sir,
So SFU grade 2, SFU grade 5, 0 to 5,
0 to 4.
0 to 4. So you tell.
Sorry, sir. So grade 0 is when there is no. Sir, grade 0 is when there is no dilatation of the calyces or renal pelvis, and in grade 1 there is only renal pelvis that is visualized, but calyces are not
Okay,
visualized.
he will
In
read
grade
just to mention it, okay.
Okay, so can you predict what is the possibility of this child with this hydronephrosis or epidiameter? It can naturally open up, or whether you should go for surgery. Can you predict this, Shahil?
Yes. Next. Renal scan can be.
Okay, Madhur, go ahead.
Just Sanjay, you asked very good question, but he could not understand it.
Yeah, yeah.
And he is asking for renal scan. You ask a different question. Dr. Sanjay is asking, what is the pathological cutoff where you will define this child will qualify for surgery, or this may go for conservative management? Could you get the question?
Sir. Yes, sir.
And Dr. Madhu has given you two classification. One is based on the APD and second is the SFU. These are the two standard classification for assessment of antenatal or postnatal childhood hydronephrosis. That has a prognostic value the way the Partin's table has been extrapolated in CA prostate based on various criteria. Similarly, APD as well as SFU grading, they also has prognostic value. So based on these parameters, in which SFU grading you will keep this child, APD values have also been given. So seeing at first sight these parameters, what will be your first makeup, and you will counsel the parents that this child needs urgent surgery, or what is the likelihood of surgery on subsequent follow-up. Both the findings are there. दोबारा से दिखाओ इनको PAPD, दोबारा से दिखाओ मधु इनको अल्ट्रासाउंड की finding. Based on this, now you tell.
For SFU grade 3 and more require surgery, sir.
Yes. More require surgery. So what is the likelihood SFU grade 3? It will fail on conservative management. What is the likelihood that stage SFU grade 4 will fail? All antenatal hydronephrosis has to undergo into certain policy. What is that? And what is the pathological cutoff for PAPD? Suppose he is giving a क्या है PAPD इसका मधु?
Sir, 7.2 centimeters, sir.
7.2 centimeter. My God, it is just almost just like a kidney. anterior posterior diameter in an adult. So what is the value of this 7.2? And what is the minimum cutoff for pathological hydronephrosis? So, Madhu, if you know that, tell us, otherwise we move forward.
Sir, the maximum APD that is considered normal is 15 mm, sir. And there is a chance that SFU 1 and 2 grades will recover in most of the cases, sir. But the chances of requiring surgery in SFU grade 3, I don't know, sir.
All kids, yes, see, all kids above 1.5, they should be further evaluated with the suspicion of obstruction. Anything which is greater than 10 millimeter has to be seen with suspicion. So 10 becomes pathological.
And anything beyond 2.5 is very significant. And you should
2.5, yes, 2.5 means which baby has to go, most likely will require surgery.
So there are certain papers from our center and other world literature also. So if more than 2.5, 60-70% possibility that he will require surgery subsequently.
So most of the time, the diagnosis of UPJO obstruction in children is based on ultrasonography. Scan may or may not help you, and rather sometimes scan makes things difficult to diagnose
Hi,
and
Namaskar,
concept.
Doctor. I'm confused between
So-
postnatal ultrasound finding and antenatal finding. Hello.
हाँ sir, बताइए sir.
Hello.
हाँ,
Just
हाँ,
I
sir.
want to. I just confused about postnatal APD finding. Is there any grading about APD? APD is 7.2 centimeter. What does it mean?
Sir, this is anteposterior diameter of the pelvis, sir.
Yeah.
Okay,
What
so
does it mean actually?
actually,
It has
what-
got any significance over the surgery?
Yeah,
Whether,
and for the last 10 minutes, this topic has been discussed.
okay.
Yeah, this has been to Sahil. It has been Sahil. Now you have been told. Kindly reply.
So for grade 3 and more, it requires surgery. 1 and 2 can be managed conservatively.
According to APD, actually, I just
Yes.
wanted.
Yeah, he is asking in terms of APD. Is there any this clinical value for a pelvic anterior posterior diameter?
It helps in grading of hydronephrosis or APD.
Grading, this is just I want to know whether it is less than 10 or less than 6.5 or more than 7.5, or this is I want to.
sir, what we are discussing, if APD is more than 1 to 1.5, then it is very significant. And if it is more than 2.5, the child is likely to go for surgery. This is what we were discussing, sir. APD 2.5 centimeter, right? So Madhur, you go ahead.
Thank you.
Thank you, sir.
I had a few more slides about APD, but
Not equal. You go further.
I will,
So,
sir.
Shahil, you got those APD. So, and what next? You want for any further scan, or you want to go for surgery, or what?
Sir, we will go for renal scan.
Okay, so show the renal scan.
Sir.
Okay, Shahil, can you?
Left, yes, sir. Left kidney is obstructed. sir.
How do you think that is obstructed? What information these all those curves and this images giving you? What are the information that this image is providing you?
Sir, after giving diuresis on 20 minutes, the curve is not going down.
So what are the part of this scan?
Sorry, sir.
What are the different phases of this scan? What you usually try to look into a standard diabetic renal scan?
Arterial phase with perfusion phase and
What arterial phase?
perfusion phase, sorry, sir.
Okay. So what you are seeing in this images in perfusion phase? And
Kidneys
why it is
hyper-
important? Why it is important?
kidney is perfused or not, stenosis हो सकता है सर renal artery का.
Renal artery stenosis in renal scan? Right. So do you think that this diabetic renal scan is a good, important evaluation criteria or diagnostic modality for renal artery stenosis?
No, sir.
You are saying that with perfusion you can rule out renal artery stenosis or something. You are saying, no? Okay. So what you want to see into the drainage stream?
We will compare it with the other kidney and Lasix after giving Lasix, whether the drainage is not occurring or not at the level of PUJ.
So whether there is a drainage in, so in this image, can you see the drainage of left kidney, or what is your interpretation seeing the drainage?
It is prolonged. I can see the T half.
Madhur, is there any other images?
Sir, no, sir. Only these images are there, sir.
Okay. So what is this curve? The no. What are the different curves you see in images? The diabetic renal scan. What are the different types of drainage curve you can come across?
Sir, 1, 2, 3 curve or really curves are there.
Okay. So what is 1, 2, 3 oral curve?
Sir, one is normal unmodified renogram is there. In pattern 2, there is a rising curve. It continues to rise after Lasix, indicating no washout in response to increased flow rate. And there is curve 3A and 3B. In 3A, washout occurs in response to Lasix. In 3B, there is partial washout. And 4 is delayed double peak or Homsey response curve is seen.
Okay.
Mm.
So what is the significance of 3A and 3B?
In 3B, it is a equivocal response occurs, sir.
If a child, if you see this kind of 3B kind of curve,
Yes, sir.
is there any way you want to ascertain that there is obstruction or not?
If there is an equivocal response, we can go for Whitaker test to definitely demonstrate PUJO.
Okay. So what is the importance of different protocol of Lasix, like F0, F minus 20, F plus 20? Is there any specific scenario when you use different protocols, or the same protocol should be used in all cases across the board. Since there are different protocols, that means there
Yes.
must be some use of
Yes, sir.
this protocol, right?
Sorry, sir.
Anyone can put some light on this? No. Okay, I think next, Madhur. Child, what else you want to know? Anything else?
Nothing.
No? Okay.
Okay.
So tell the findings of this report, Madhu.
Sir, the left kidney has a GFR of 9.38 and the right kidney has 49.77, and there is a very poor drainage on renal scan for the left kidney. The right kidney is normal parenchymal function and drainage, sir. There is no issue with the drainage as such, sir.
So the GFR is 9.
Yes, sir.
Shahil, so you want to preserve this kidney or you want to take this kidney out?
We want to preserve this kidney.
You want to preserve this. Okay.
What is the percentage function, relative function
The percentage function would be around 20%. If you see, it is
on DTP?
the right kidney is 49, right? And it is 9. So almost 18 to 20% function, if you see the percentage.
Okay.
Right. So, Shahil, so what? How will you proceed?
I would like to operate on this patient and we'll do pyeloplasty in this patient.
Okay. So, do you need any further evaluation, or this ultrasound and scan is enough for you?
Sir, this is enough. On ultrasound and renal scan, I can go for management of the patient.
Sahil,
Yes, sir.
is there any role of RGP in this patient?
Yeah, intraoperatively, I can go for RGP.
You can means, is it a standard protocol for all patients? How do you choose where you want to do an RGP and where you would skip RGP?
So in this, we haven't gone for CCT. So we can go for RGP and then proceed with the definitive pyeloplasty.
Okay, so if a CT has been done, then RGP is not required.
What are specific findings in CT that will make you that will ensure that you don't need an RGP? What you are basically looking in CT scan that can help you to avoid RGP? This is what sir is asking. What additional information that will help you and you will avoid RGP?
Is RGP a standard protocol in primary UPJ obstruction?
No, sir.
Then why did you become a victim of the trap which has been laid in front of you? It is not necessary to reply all questions.
Yes, sir.
And
Yes.
does any book mentions RGP ever in primary UPJ obstruction?
No, sir.
Then why CT, why RGP then? What may be the specific conditions when one may think for RGP in cases of UPJ obstruction?
In case of secondary UPJ, we can go for RGP. Not in
Yes,
primary.
because the objective is different in secondary UPJ obstruction.
Yes.
What other possibility can be which may force you to do RGP sometimes?
Have you ever come across a PUJ in a duplex system?
No, sir.
Yes, that is
They-
not very uncommon. In duplex, UPJ is quite common. So that is one condition, and any other more common conditions which might confuse urologist, especially when the sonologist is not confident, is repeatedly writing there is a hydronephrosis, significant hydronephrosis, SFU grade 4 or grade 3, and there is a dilated ureter, and you yourself is not sure whether this is primary UPJ obstruction or this is a mega ureter which is leading to disproportionately dilated kidney above. Is not that?
Yes.
Yes. So CT in primary UPJ obstruction is usually not recommended. RGP also is not recommended. Unless you have some these 3-4 conditions.
Okay.
Okay, so how will you manage? What surgery you are planning for?
Sir, pyeloplasty.
What kind of pyeloplasty? Open, laparoscopy, any specific type of
Open
pyeloplasty?
Open pyeloplasty, sir.
Open. Which type? Is there a
Anderson height.
Anderson? So, Ansari sir, would you like to ask any further question? Because I think we can finish this case, and we don't have much time, so we can. I think today one case is fine. I think.
Dr. Sanjay, I have one question.
Sir, please.
Not regarding this patient. Suppose a percentage function of the kidney is about 8% with very low GFR. That what will be the management in about 5-year or 6-year-old male or female? Should we take out the kidney?
Ansari sir, would you like to answer, sir?
Please repeat the question.
Sir,
Asking if the percentage of function is 7-8%
Yes.
in a pediatric.
In pediatric, policy is altogether different. We do not follow 10%. Yes. The policy in pediatric is to preserve the kidney as much as possible. And as such, there is no criteria, but at least up to 5, one should give a chance to go for the corrective surgery.
okay. Thank you, sir. Thank you.
So, Apul Goel sir, are you there, sir? So
Yeah,
I
I think Sanjay, because I think if any other faculty want to ask any question, otherwise a second case will not be. We all will get delay for the OT.
yes, sir. I think we can conclude this session today, sir. Second case is not possible now because it is already almost 8:52.
8:50.
Yes, sir. So I think we
Yes.
can do it in some next other day, maybe after 2 weeks or so, sir.
Yes, because already.
Yes, sir. Samir sir, what do you think?
Yes, Sanjay. I think second case won't be possible. So my general comment to Sahil would be, I mean,
Yes.
but my advice would be to be more prompt and more precise in answering. See, your time is limited, both here and in exam. You have a limited time for a case. The more you delay in answering, the more you beat around the bush, you are kind of harming yourself. Your strong clinical things. If you waste too much time during history and examination, then you are excluded from answering about the important questions regarding clinical management. So my advice would be to be more prompt and be quick with answering. If you don't know, just say it and move on.
Right, sir. Thank you for your feedback. Okay, sir. Wish you everyone happy and safe New Year, sir. Thank you, sir.
Thank
Thank
you very
New Year, everyone.
Thank you.
Thank you.
Thank you, sir. Okay, sir. Apurva sir, we are concluding today because we
Yeah.
don't have time, sir. Right, sir.
Yeah. I was.
Thank you.
Thank you.
Thank you.
साहिल तुम यार मतलब दूसरी मतलब ना बोल रहे